Uncle Bob, cue Uncle Bob.
Yes.
Give them a big welcome back, clinical problem solvers.
Welcome, clinical problem solvers.
Well, good morning, everyone. We are so excited for another edition of RLRLR. That first R stands for Robert, aka Bob, aka Uncle Bob, a superhero in medicine. And yeah, very excited. We have who's scribing today and who is teaching? Ayesha, what are you doing today?
Hi, good morning. I'm scribing.
Say a few words.
Hi, good morning. My name is Aisha, and I finished med school 2 years ago from the Middle East, and I've been part of CP Solvers since March, and I love it. Thank you so much for
I,
having me today.
Ayesha, we can be on a magazine. Who wore it better?
You definitely did.
No, no, don't stop it. There's no chance. And who's teaching today?
I am. Hello, everyone.
Yes, hi. How are you?
Hi, I'm good, Prof. Rez. Finally, I'm gonna get your name right. I
You
call
can
you
always
Doc.
butcher my name.
Pleasure to be here. I'm Umesh Dino, and I'm a CP Solvers Academy member as well. And it's really special because I just found out that Dr. Robert Center is the creator of the central criteria. So today makes it all the more special.
Don't mess it up. I'm just joking. With that being said, why don't we start the case, Uncle Bob? Be kind to. Oh, wait, Uncle Bob, you have someone to introduce too, right? Before
No,
we
he
jump into
couldn't.
the.
He couldn't make it because he's on night float, and I
Okay,
told him to get some sleep.
perfect.
He
Well,
presented
whatever.
the case. He presented the case to me. His name is Todd Veal, one of our very good third-year residents.
Beautiful. Let's transition to the whiteboard. And just so everyone knows, I'll dip out at 9:30 for just 6 minutes. Hopefully, by the time I come back, the case is solved.
Are we ready?
Let's rock
So
and roll.
a 64-year-old man is brought to the ER after a syncopal event. That's all you know. You get a call. We're bringing a guy, 64-year-old man, who had a syncopal event.
Hey, I only have two pieces of advice to share with everybody now, which is I think you want to translate the syncopal event, which is a diagnosis, to a more factual statement of what actually happened. It's very likely that the patient had a transient loss of consciousness, for which there's a differential diagnosis, or the patient had a fall, for which there is a differential diagnosis. So for me, what happens is I often am at the receiving end of these ambulance calls and immediately have to do some untangling to make sure that I don't latch onto a word and my mind doesn't grasp onto it. So one big piece of advice: take syncope and delete it and replace it with what actually happened to the patient, either as a fall or a transient loss of consciousness, which are the two most accurate labels. The question will be, how will you get those labels? And I cannot tell you how important it is practically to speak to the EMS who brings the patient. And the things that I will ask the EMS folks who brought the patient is, who witnessed this? What did they see? What was their description of the scene? And how did the patient look at upon their arrival? And what did they administer to the patient? What were the vitals and sugar? And what was the route like on arrival to the emergency room? So the key historians in this situation are the EMS folks, and all too often, the gem of a history that they provide gets translated into a word of mouth from person to person to person to person. And for a chief concern that is dynamic and often vanishes before it returns again, your only chance of high quality data is to talk to the people who are there. So for now, what would I be doing? I would be discounting syncope and translating it into a more specific entity, and would be talking to the people at hand to minimize the risk of going down the wrong path because of a discrepant history. All right, Uncle Bob, back to you.
At 4 a.m., he was walking from the kitchen to the bedroom. He suddenly collapsed and lost consciousness. The wife heard the fall, found him, and to quote her, he was clammy, diaphoretic, rigid, eyes had a blank stare, and he was foaming at the mouth.
So, Uncle Bob, this is extremely helpful. And oftentimes, what we deal with as clinicians when someone comes with transient loss of consciousness is whether we're dealing with syncope or seizure. And the sudden onset of symptoms really suggests an electrical abnormal activity. The question becomes, was it at the brain or was it at the heart? The thing you have to realize is that convulsions themselves don't distinguish syncope from seizure, because post-syncope, you can have convulsions. And something that Robbie said, which is really important to realize, is not so much the prodrome, the event, but the post-event analysis really helps with prioritization of the DDX. And I'll just give you a quick example. In someone who has a seizure, they may have post-ictal confusion that persists for 30 minutes or an hour. Someone who has an arrhythmia and then suddenly has transient loss of consciousness, when they come to consciousness, they do feel out of sorts, but they're not confused. Here, with the blank stare and the foaming of the mouth, you may prioritize seizure over arrhythmia of the heart, but you really can't do that completely. And we don't know if the patient ingested something or not. So all I can tell you with this information from the wife is that there's some kind of electrical discharge. The question is that at the brain or the heart? So more information is going to assist us. And this is, I think, like a few physical exam maneuvers when you're trying to tease syncope versus seizure. Just look at the tongue, see if there's any kind of tongue lacerations. Its presence increases the post-test probability of seizure. Its absence does not exclude, like many physical exam findings. So UB, Mike, back to you. But right now, I'm just worried about aberrant electrical activity.
Well, I'm not going to give you that just yet. He was incontinent of urine. He was unresponsive for 10 minutes, and that's when she called EMS.
Uncle Bob, the urinary incontinence, I think historically has been attached to seizure, but it actually occurs equally frequently in syncope and has essentially no diagnostic value. Apart from confirming that the patient had a sinister event as opposed to a bland mechanical fall. So what does the urinary incontinence tells you? It tells you, just like sinus tachycardia, that something bad has happened, but unfortunately has little specificity in distinguishing between the brain and the heart. The fact that he was confused thereafter strongly supports that there is something intrinsic in the brain going on and supporting the notion of a seizure. However, a syncope with a concussion is also an intra-brain problem, and somebody bonks their head when they fall from a cardiovascular issue, causing a subdural hemorrhage or a bland concussion. So you can see how the whole goal of syncope versus seizure is an endless journey that can only be done with escalating confidence with more data until you get more and more concrete data that there's something wrong. And even then, you could actually have mechanisms of syncope and seizure happening simultaneously. So urinary incontinence doesn't move the needle at all. The unresponsiveness for 10 minutes pushes us towards seizure, but syncope with a concomitant brain trauma, either a bland one like a concussion or overt one like intracranial hemorrhage, is equally plausible.
Okay, he did awake, but was lethargic and confused for about 20 minutes. Does that?
Oh, is it not time to go yet? Okay, please.
Does that help you, Reza?
Yes, I'm loving this, like one sentence at a time. We've never done it like this. This does help. You know, Uncle Bob, when we had the initial information that there was a thud, then we layered on that it persisted for 10 minutes, which prompted Robbie to prioritize seizure, but not exclude syncope and a complication from trauma. But here, now we have confusion after the event. So it persisted for 10 minutes. There's confusion after the event. Now we're starting to make a strong case for abnormal electrical activity within the brain. that is a seizure. And Uncle Bob, let me know if you want me to start talking a little bit about like how I think about seizure, or if I should just pause and wait for more data from you.
I think you could go ahead and do a soliloquy.
Okay, awesome. Seizure, you shouldn't be nervous about approaching seizure. Why? Because everyone on this virtual morning report has an approach to altered mental status. And that approach to altered mental status is missed. Aaron Berkowitz changed the mnemonic from missed to NMIST. That's neuro plus missed. Look, this patient is 64. So one of the things that we have to do is look for a secondary cause of seizure. And when you're looking for a secondary cause of seizure, where that N comes into place is really, is there some pathology within the brain or not? Meaning something intracranially or not, or is the pathology within the blood that coats the brain that leads to the abnormal discharge of electrical activity? So a patient like this, you're going to get a CT of the head. That is a low-hanging fruit. And I have to say one more important pearl. If this entire episode was witnessed based on where the patient had abnormal activity first, may allow you to localize the actual site of seizure. So for someone like this with loss of consciousness, sort of on the ground, this is a generalized seizure. It's unclear if they had tonic-clonic activity or not. And then as far as the secondary etiologies, just think about the metabolic processes, the toxins, whether it's a medication that has been taken in excess dose or a medication that the patient has not taken and is now having withdrawal like gabapentin. So this patient, if they come to the emergency department, it's crucial to get them to a monitored unit for epilepsy, though we wouldn't define this as epilepsy because he's 64 and we have to look for an actual etiology. So this person needs to be attached to an EEG. Note that when you do the EEG in the moment after the event, you may not actually capture the seizure, but you could see some abnormality within the brain that may suggest that a seizure in fact had happened. So UB, where we are right now is prioritizing seizure, but seizure is just a proximal diagnosis. It's not a terminal diagnosis. We are running towards what can be driving this aberrant electrical discharge from the brain.
So he was found very quickly after he fell because his wife was right there in the bedroom, and he was on the way to the bedroom, and they did not see any obvious seizure activity when looking at him. When he awoke, he did note that prior to the episode, he'd had chest tightness. He had no other symptoms previously, has never had anything like this before, and only has a past medical history of hypertension.
Yeah, Uncle Bob, at the end of the day, I think that nobody can confidently diagnose seizure or syncope until one thing happens, and that one thing happens is you find a reason. So right now, if you play back you finish this whole hour hypothetically, and you tell us the patient was diagnosed with a brain mass, we'll probably say they seized. But if you tell us that the patient was diagnosed with a pulmonary embolism, we'll say that the patient probably had a syncope. So what happens in real life? I think in real life, you have to continue to pursue both hypotheses at the same time when the index of severity is so high. So you're seeing how we're constantly oscillating between seizure versus syncope. And the mistake to make is to try to assume you know for sure what happened and go down the evaluation of brain or thorax and forget the other side. These patients get simultaneous evaluations for both because their index of severity is so high. If a patient had a mild episode without falling, without such dramatic findings, it's very, very easy to say to go down one path, but this patient deserves both. And the both is authentic to the idea that you can have both diseases happen at the same time. And we can reflect on that. But a simple example is you have metastatic cancer to the brain and you have a pulmonary embolism. So I think for me now, the strength of the evaluation is going in both directions, though the presence of the chest pain heightens the concern for propelling towards syncope faster. I would argue that if you cannot tell between seizure and syncope at face value, you should probably move towards syncope faster. Why? Again, let me make that statement again. If you, like this case, are getting a headache just thinking about which one it is, I think you should proceed with evaluating syncope. Why? Syncope is basically temporary death. That's what's happening to the person. They are temporarily dying. Versus seizure is definitely a morbid issue and can turn into something ridiculously morbid called non-convulsive status, but it doesn't turn into death. And so I would argue that this patient is probably going to receive an extensive evaluation assessing both, but the morbidity of disease lies in syncope. So for me, what would I be doing in real life? I would be waiting for the two S's that are easy to obtain, which is what's the sugar and are there any substances on board? I can't tell you the number of times substances sneak up on us in a history that's as tricky as this. Sugar and substance right away. What are the substances? Opiates, alcohol, marijuana, many, many things. But then what's the next step that I would want? I would want an EKG and a stethoscope right away. And if I'm not happy with the EKG and if the EKG and the stethoscope don't give me an answer, this patient's going to the CT scanner. But it's not one CT scan, it's two. It's the CT of the head for seizure plus rule out subdural, and it's a CT chest with contrast. Because all too often, it's so easy to miss structural causes of syncope, with the two P's being the most morbid, an acute pulmonary embolism or a rapidly evolving pericardial effusion. This patient with this degree of compromise in his life and the fact that he had chest pain beforehand means he needs the whole shebang. So this is the kind of patient that gets rapid evaluation in the ER. Point of care sugar, MedRec, EKG, stethoscope. If there's an answer, you see a prolonged QTC or you see a delta wave, you probably would get a CT head and call it there. But if there's no answer on the EKG and the stethoscope examination for aortic stenosis, this patient gets a CT chest with contrast. Professor, I think there's so much juice and reflection here that I'd love to pass the mic to you to see where your mind is at before we get peppered with more information from Uncle Bob.
I'm right where you are, my friend. Zero to add. And in reality, I love the idea of like pursuing both pathways. And we're not going to be able to rule out a seizure with a spot EEG, but we can rule out ACS, PE with a spot EKG, troponins, and CTPE. So yeah, we're going to go down both pathways and see where Uncle Bob takes us.
Okay, so his sugar by EMS was totally normal. He arrives in the emergency department and the vital signs, his temperature was 97.5. His heart rate was 77 and regular. His blood pressure was 149/106 and did not vary from arm to arm. His respiratory rate was 16 and unlabored with 98% O2 saturation. A note from the ER said he was orthostatic positive for diastolic blood pressure. That was not confirmed on the floor. The cardiac exam said mild tachycardia, but he had a heart rate of 77 and his lungs were clear. The rest of his exam was totally unremarkable.
Yeah.
Go ahead, Professor. Sorry, I forgot. It's your turn.
Oh, no worries. Did you want to go?
No, I was, yeah, no, not at all.
Okay. I think, Uncle Bob, something that's really important, we all need to be mindful before casting doubt to the vital signs that was obtained by EMS. Understand that the patient is no longer having the insult that prompted them to come to the hospital. Meaning we're now evaluating a patient who isn't undergoing that transient insult. So we have to take that into account. So the exam, while reassuring, isn't really reassuring because the patient hasn't had the event. The orthostasis, I think more important than actual changes in systolic or diastolic is how does the patient feel when they stand upright and change posture. But it would really surprise me if this presentation ends up being all orthostatic hypotension. Though you can imagine it's early in the morning, he got up to go for a walk, becomes orthostatic, and then boom, thuds. The other thing I want to mention is this blood pressure in both arms. Just realize this doesn't really reduce the post-test probability of aortic dissection because only 10 to 15% of patients with aortic dissection actually have a varied blood pressure. And most often a varied blood pressure is because someone has some atherosclerosis in their subclavian artery. So UB, what this does for me is just tell me that I need more work to do, meaning I need to connect this patient to the telemetry in the event that they might have another episode of loss of consciousness. We need that EKG, we need that troponin, we need the non-con CT head, we need the CTPE, and yeah, and we go from there.
Well, I'm going to give you POCUS first because the resident goes down to see the patient and brings his butterfly with him. Says that he has a grossly normal LVEF. He believes with a question mark that he has a dilated RV and RA. And the IVC is obscured by bowel gas, so he can't estimate the IVC. There are no B lines on POCUS of the lungs.
Oh, we have some POCUS experts here. Ravi is here, and I know many of the CP Solvers Academy folks are equally interested in this space too. Prof. Rez, I just wanted to refine one teaching point that I made earlier about why we should, because you just made it so clear to me by saying something earlier that I wanted to reflect on, and then we'll talk about this. We were talking about seizure and syncope and how if you can't tell, you should go syncope because it's more morbid. But you just made me realize with your comment that actually you can make so much more progress on syncope than you can make on seizure. And of course, you can find something bad in the brain and on imaging and posit that the patient had a seizure, but like the syncope eval is so much more rapidly productive than the seizure eval, which we often grapple on. And that's one other reason to prioritize it. And I think you're seeing that productive workup for syncope here bear fruit with the patient having features of right heart strain on the POCUS. And that's what essentially this means, that there is a dilated RA and RV, and that dilation as that probably as a result of pressure overload. The quality of the POCUS is a function of the butterfly and the operator and the interpreter. And since this is not standardized, meaning that this is a ultrasound done by somebody at the bedside, it's not somebody who is as experienced as a radiologist or a cardiology fellow or an echocardiographer. You have to take it with a grain of salt. But I think it's data that's profoundly impactful. So with that idea that you have to take it with a grain of salt, let's just interpret it as if it's true. And now you know the patient has evidence of right heart, high pressures in the right heart. What you don't know for sure is the time course. You don't know if this is a patient with pulmonary hypertension who has progressed to syncope, or this is a patient with acute pulmonary embolism. But there are some features of the heart that can help you predict whether this is acute or chronic, and the best one is the RV wall thickness. With chronic pulmonary hypertension, unfortunately, the RV wall reacts to that and becomes thicker and thicker and thicker and thicker, adapting to the pressure overload that it is under. A patient with the right heart strain without any evidence of changes in their RV wall, namely thickness, probably has acute pulmonary hypertension. But yet again, we now have syncope. We prioritize cardiac syncope, which comes in two different categories: a structural cause or a arrhythmogenic cause. The pre-existing chest pain, along with the evidence of right heart strain, supports the notion that there is a structural cause, which is assessed in two different ways: a CT chest with contrast or an echo. The fundamental difference between those two tests is whether they are looking at a cardiac issue or a pericardiac issue. You can think of all the structural causes of syncope as either being primarily cardiac, like aortic stenosis or hypertrophic cardiomyopathy or mitral stenosis. They're in the heart, versus structural causes that are around the heart, like a pulmonary embolism or a pericardial effusion. The pericardiac structures are more morbid than the intracardiac structures. So it's much more morbid to have a PE or a pericardial effusion than it is to have aortic stenosis or hypertrophic cardiomyopathy. So if you're worried about a structural cause of syncope, the first step is to get a CT chest with contrast to help you see, does the patient have a pericardial effusion or a pulmonary embolism? The POCUS is a great initial test to make a pericardial effusion less likely, but it's imperfect and can miss posterior effusions, for example. So I think we would definitely get the EKG and the troponin, but I think now there's even more reason to get a CT chest with contrast than there was before.
Okay, so at this point we get a CBC, which shows a white count of 6, a hemoglobin of 15.9, and a platelet count of 161. The first troponin comes back is 0.9, with 0.3 being the upper limits of normal at our hospital. His urinalysis shows 2+ protein and a creatinine of 1.1. He has a chest X-ray, which I can show you in a few minutes, but it's read as unremarkable, and he has a CT of the head that shows no abnormalities. And I think Reza had to leave
Yes,
for 6 minutes.
Yeah, I'm gonna have to leave for 6 minutes and to do a quick IDR. Just what I take from this, Uncle Bob, is that the troponin is just telling us that there's myocardial cell death. It doesn't tell us what's causing the myocardial cell death. So in this case, so far, this would still be very consistent with a pulmonary embolism. What we'll need is an electrocardiogram and then a stat CT PE. The good news is that the blood pressure is elevated. So even if we find a pulmonary embolism, despite the syncope, it would not be considered high risk, aka massive PE, which has 100% mortality unless you give thrombolytics. So here the blood pressure is quite reassuring. And Robbie, just to refine the thought I had, was that in aliquot 1, when we heard the thud, we didn't have the chest pain. So we prioritized aberrant electrical activity, but we could have set obstruction of a vessel back to that OG schema of sudden onset of symptom. So UB, what this does for me is not much, but I know you love the creatinine, so I want to know his muscle mass and what his cystatin C is. Okay, I'll see you guys in 6 minutes. Bye.
Oh my God.
Okay, just to give you a little bit more, and I'm unfolding this the way the case actually unfolded.
Yeah.
But 5 hours after hitting the emergency department, he's admitted to the hospital. His troponin is 5.5. And 5 hours after that, it's 4.5. He has a pro-BNP of 68. So
Uncle
now
Bob.
you have increasing, and then I'm going to work. What I'm going to need to do is have you show me the screen. After this, I'll start showing you some things that cannot be done otherwise.
All right, perfect. Uncle Bob, since Prof. Rez is gone for 6 minutes, I figured we would do something we haven't done before, which is to do a 5-minute breakout room session. So I've opened up 10 breakout rooms. Please, please, please feel free to hop in and chat amongst the many people here about what you think is going on. And we'll come back in 5 minutes. Awesome. Sorry, Uncle Bob. There you go. Okay, X-ray is normal. Rafael, you want to take this one?
Absolutely, be happy to. So whenever I'm looking at an EKG, rather than going through that like 6-step process they teach you in medical school, I ask 3 questions. The 3 questions I ask is it fast or slow? And just like eyeballing this, it looks like it's fast. I say, is it narrow or wide? Looking at this, you can be fooled. You have to be a little careful, but overall, I'm leaning towards narrow. Regular or irregular, it looks regular. And in fact, I can see a P wave in 2 and before every QRS. So this is sinus rhythm. And then looking at the axis, I look at 1 and 2. And the reason the axis is important here is because we are expecting potentially right axis deviation based on what we saw on the POCUS, but we had to be cautious with that POCUS because it wasn't done with someone who has training in that domain or is certified. So UB, the next thing I look at is ST segments, and it's not easy actually to look at ST segments. What will be helpful for you as like early learners, if there are any in the audience, is identifying the isoelectric line. And the way to do that, I like literally take something and I look at the preceding PR interval, if there is a P wave, and that becomes my isoelectric line. And then I go in the I go in a sequence of leads that make sense. So contiguous leads. So looking at 2, 3, and AVF. So 2, there is no significant ST segment elevation or depression, but there is some flattening of that ST segment. I hope you can all appreciate that in lead 2. Looking at lead 3, you do have this inverted T wave, but you can have an inverted T wave. But then you look at AVF and you're seeing that there is some T wave inversion and the ST segment seems to be abnormal. So looking at 2, 3 AVF, you're starting to get a sense of that inferior leads. Remember, these leads are capturing primarily the left ventricle, but that 2, 3 and AVF gives us some insight into the right ventricle as well. And then I'm going to look at my lateral leads, 1, AVL, V5, and V6. If you look at V5, look at that T wave. It looks unusual, huh? Some T wave inversion. So Robbie, I'd love for you to comment. And by the way, everyone is going to say S1, Q1, T3. The reason I don't even look at that is because if you ask the question, what does that do in terms of the likelihood ratio for a pulmonary embolism? It doesn't do much, folks. It really doesn't. The likelihood ratio is 1. So its presence or absence doesn't help you, but it can give insight to RV strain. And then looking at the anterior leads, V1 through V3, you also see that T wave inversion. So overall, I would say this, that it's looking like you're having some RV strain. You're having diffuse abnormal T wave inversions. There aren't any SC segment elevations that would meet the criteria for STEMI. And I will leave it at that. But Robbie, would love to hear from you. Anything that I missed in that?
Not at all, Prof. Reza. I think that's absolutely superb. Well, awesome, Reed.
So just to reinforce what Reza said, there's the S1, Q3, T3. So that bottom CT angiogram. Let me get back to Zoom, unshare. Let's see, stop share. And I can go back. And as was so beautifully predicted by our outstanding team of discussants, patient did have a pulmonary thromboembolism of the right main, the right middle, the right lower lobe, and a branch of the left lower lobe. It was, as best we know, unprovoked.
I'll just share a brief reflection, Prof. Reza, and I actually would love to learn from you because I know you had to actually literally take care of a patient with a PE, like what your advice is on treatment and workup and whatnot. Because honestly, I'm kind of weak in that. I just kind of diagnose the PE and admit the patient to the inpatient team. My reflection is this. I think everything in medicine, in medical, is taught equally, you know, how to interpret labs, how to interpret everything. And I've been sharing to Prof. Rez how much I really have come to believe that 99% of the answer is in the history. And not because I think that you can come to a conclusion in the history, but if you don't start by taking as much advantage of the data that the patient is giving you, you're going to be far astray. And I think you can see how, based on the history alone, you can make a strong argument for getting a CT chest with contrast just from listening. And I would highly encourage you, instead of me repeating that, to like listen to the conversation that Prof. Rez, Uncle Bob, and I were having in the first alquat, and why it became so abundantly clear that this patient needed a CT chest with contrast. And this is why the history is the most powerful variable, because guess what? Are you more likely to see an S1, Q3, T3 pattern if you are already thinking of PE? Are you more likely to see the RV strain if you're thinking of PE? I think that the answer is yes. So for me, it's medicine truly. I used to like laugh at people who would say 90% of the answer is history. Like, how is that possibly true? What I think that means is that if you don't listen carefully to your patient, you have a 10% chance of getting the diagnosis right.
So
yeah.
let me throw in something. When I presented this to one of my very experienced colleagues, great clinical reasoner, and he was very impressed with the diaphoresis, and he felt the diaphoresis was a major clue. And one of the things that came up immediately when he saw diaphoresis was pulmonary embolism, and that many of the diagnoses fall out because they don't cause diaphoresis. So I throw that out to you as a possible extra valuable piece of information in the history that I probably would have overlooked, and just would love both of your thoughts on diaphoresis.
Uncle Bob, thanks for mentioning that. I am gonna ask Robbie to comment on that while I just talk a little bit about pulmonary embolism. And I think it's such an important topic. And this is on our RLR website. And this is our 4-step approach to once a PE is diagnosed. And the first step is risk stratification. And it doesn't matter how much thrombus you have in those pulmonary vessels, those do not determine the severity of the PE. It just comes down to blood pressure. And it's not just blood pressure on arrival, because remember, this guy's blood pressure was probably low when he had the event. That doesn't mean it's a high-risk PE. It's like, what is the blood pressure after you give a liter or 2 of fluid? It's almost like that patient with end-stage or kidney disease and you're trying to think of dialysis. Yes, dialysis once you try your medical stuff, and if that doesn't work. The intermediate risk is RV strain. And you can make this diagnosis based on a couple of facts. One is just the EKG. Here, the S1, Q3, T3 tells us there's RV strain. Again, it does not tell us that we have a pulmonary embolism. It does not tell us that. It tells us that we have RV strain. The troponin elevation tells us we have RV strain. And then you can actually look at the CT scan, and if that RV is the same size as the LV, you have RV strain, the anterior structure. The POCUS already alluded to that being present. And just really quickly, so Robbie, this week I've been triaging as MOD, and we got a call where there was like a little bit of disagreement where a patient should be admitted, cardiology or medicine. The patient had a subsegmental PE, had a BNP that was elevated. The trope was normal, no strain on CT scan, and had sinus tachycardia. So there is a disproportionate in terms of a subsegmental PE causing that degree of BNP. So it was really nuanced at heart failure. The EF was 25%, not because the P was just an incidental finding in someone with COPD, which we see in 10 to 15% of patients. But why do I say all this, folks? What's going to happen is 99% of the time, these patients are going to be started on heparin. I think it's sort of like that debate when you talk about IV contrast, does it cause nephropathy or not? I will tell you this. I strongly believe that Lovenox is the way to go, not heparin, low molecular weight. And this is why, because the pharmacokinetics, you get immediate action of the Lovenox, while the heparin is a nuisance to the patient, the nurse, and the providers. And you'll see the PTT go to 200, then we'll stop. It's terrible. So if the patient is a candidate for Lovenox, go with Lovenox. And what this patient's creatinine is pretty much fine. He should be fine for Lovenox. But if you had a low risk, then you can go straight to your DOAC. The Lovenox is preferred over the DOAC for the intermediate risk because the DOAC just hasn't been studied and it's immediately effective. Then the duration, Uncle Bob already said, one of the most important branch points in pulmonary embolism is it provoked or unprovoked. Here, we don't have a known provocative factor like a surgery, immobility, or an underlying malignancy. So it's probably going to be unprovoked, and it's either going to be indefinite or 3 to 6 months. If the patient's not bleeding, you probably will continue the anticoagulation, and you don't need to do a crazy workup. They've shown this over and over again in New England Journal of Medicine. All you need to do is make sure that there's age-appropriate cancer screening. And for me, Robbie, like, this is my style of practice. In someone who's younger with a pulmonary embolism, I also work them up for antiphospholipid syndrome. That's the one thing I tend to evaluate for. And then if I can give you guys just one more pearl, and that's right here. Do age-appropriate cancer screening, and then know these patients are at risk of CTEPH, so you have to keep an eye on that. And they're at risk if they have an underlying DVT. I tend to get ultrasounds just to see if there's a DVT. They're at risk of post-DVT thrombotic syndrome, which can be quite painful. So you need to be familiar with this. I'm going to pass the mic to Robbie to comment on the diaphoresis.
Prof. Rez, that was amazing. I'd love to learn from Uncle Bob. My take on diaphoresis is it absolutely is a warning sign of rapid surge in catecholamines, which is what normal physiological diaphoresis is when we exercise. And so when you see a diaphoresis in a non-exertional patient who doesn't have a fever, that means that their catecholamines are going through the roof. The most common reason we see that is because there's a substance involved. Either they ingested something that causes catecholamine surge like cocaine, or they're withdrawing for something like benzos or alcohol. But in diaphoresis, without exertion, without heat exposure, either endogenous or exogenous, without a substance, means the body is trying to stay alive. And so it really, you run your differential diagnosis of sudden cardiac death when you have a diaphoresis episode like that. And a structural cause like ACS or a pulmonary embolism is a very, very wise observation. I'm not sure that I would have made that in real time. And it's really cool to be able to add that observation to my toolkit. It makes total sense. We definitely talk about it a lot with ACS, but it's the same idea, right? With a pulmonary embolism. What's your take, Uncle Bob? And what wisdom did you capture in this case?
I think several things is as it was being presented to me, trying to figure out if it was syncope or seizure, and I still don't know if it was syncope or seizure, because certainly pulmonary embolus could cause hypoxemia and cause a transient seizure, but trying to figure out between syncope and seizure can be very difficult if you don't actually see the symptoms of the seizure. So that was striking to me. The resident's a very good resident and did POCUS right away and got the clue that reinforced what you had said very early on. Got the clue that with right ventricular strain, you have to rule out pulmonary embolism. In real time, they weren't quite as sharp in real time. They took a little bit longer to get to the diagnosis. Now, that's because in real time, there's so many other things happening, and your mind is not set the same. The conversation I had with Gurpreet on Annals on Call about the artificiality of a CPS compared to trying to make diagnosis in real time is something we need to keep in mind all the time. But they got there, and they got there within 12 hours. The patient, fortunately, what was interesting is this guy was not hypoxic. He wasn't hyperventilating, and he was not tachypnic, and he was not tachycardic. And yet he had a massive pulmonary embolism. Now the workup was going to be done later on as an outpatient. The acute problem was to manage him, and he was clinically stable. And I think he was put on originally Lovenox and then a DOAC. But I thought it was a very educational case, and something that everybody who works in the emergency department, everybody who works on the wards It's that intersection that I thought fit you two guys perfectly. And you shined.
Oh, yeah, Uncle Bob, we always shine in your presence because of the way you set us up for reflection and conversation. I'll jump in a work, so I'll pass the mic to Prof. Rez to reflect and to Ambush who's teaching us. But I just want to thank you for coming here, Uncle Bob. We've missed you in VMR. It's been a long, long time since we've had you here. And this case is just yet another example of how the kinds of cases you bring to us and the kinds of cases we encourage everybody to bring creatinine, but the creatinine was not normal. And Prof. Rez reflected on that today in that case. And so I just love this, a diagnosis of PE, an incredibly quote unquote bread and butter diagnosis with so much learning. So if you're listening to this and you listen to this case, I hope all of you are inspired to bring more and more common diagnoses to medicine, because I think we really stand to reflect on the journey that we make. So thank you for a wonderful day, and I'll pass the mic to you, Prof. Rez, to share any reflections you have, and hope you have a great day.
Yeah, thank you, Robbie. Always a joy to co-discuss with you. And thank you, Uncle Bob. Like, I just love seeing you. And I think your wisdom on Twitter, on CP Solvers, on Annals, and all the activities you do always shine so brightly. And I want to echo what Robbie said. Like, these are the cases that we learn from. Like, this is the bread and butter medicine. And the point you made is so well said, that there's so much noise in what we do. So it's so easy to judge, like, how could they have not arrived at the DX? Yeah, because when you're actually admitting patients, it's way more complicated. And trying to capture that nuance here is the best way we can improve our diagnostic skills. And so thank you so much. And yeah, any last words before we give the mic to our lovely Umbish to teach us?
So my last words are, the first thing you have to do in your journey in internal medicine is absolutely kill the basics. You have to know all the basics. And that's the most important thing for us to teach, is all the basic things you need to know about internal medicine. I'm not going to present the Vexus case that I heard earlier this week, because that's such a zebra that it's not going to help us on a day-to-day basis.
I love that. Was that Coach Knight that always emphasized which basketball coach always emphasized the fun? I guess they all do, but someone.
John Wooden.
John Wooden. Oh my gosh. I love John
So
Wooden.
you're at UCLA.
Yeah.
Remember John Wooden.
I love John Wooden. All right. Thank you, Uncle Bob. Umesh, really excited to hear you teach us.
Thank you. So before I get started, I've shared my screen once again so that you guys can also reflect on the whiteboard while I share my thoughts. So there's always a lot of learning that goes on here, and I just want to thank the CP Solvers for creating such an enriching platform for all of us from across the globe, and something really special. You know, each and every time I come here, I learn more and more, and I see these special things. Not only do I see textbook cases, but I also get to meet people from my textbooks. Like today, meeting Uncle Bob, I cannot even believe it. It is so special. And so I'm going to get started. The problem representation, we had a 64-year-old male who presented with a past medical history of hypertension, came to the ER with a syncopal episode, which was preceded by chest tightness. During the event, he exhibited features that could suggest a seizure. It could have been a syncope. We were not sure. So as we followed the trend of this patient, we saw that there was clamminess, there was a blank stare, there was foaming around the mouth. These are some of the features that could, confuse us. But then we saw that there was no post-ictal confusion, no urinary incontinence, which are typically seen following a seizure. He was found to be awake, lethargic, but he was confused. He did not show any signs of ongoing seizure activity. The workup in the ER revealed orthostasis. He had mild tachycardia. His troponins were elevating, and there was proteinuria. The imaging workup, we went and we did a head CT, a chest CT without contrast, and POCUS. An important finding that was seen on the POCUS was right ventricular dilation, and then eventually we were all kind of thinking along the lines of a pulmonary thromboembolism, and turns out it really was the case of pulmonary embolus. So what are some of the teaching points? First things first, we need to rule out whether it's a seizure and see if it's a syncope. And then we have the famous mnemonic, which Prof. Rez added to the mnemonic, the MIST mnemonic. Now, today I know that there is an N to that mnemonic as well, which stands for neurologic. And then the M is for metabolic causes, infectious, structural causes, as well as toxins. So we want to kind of look at the history and see, where it's taking us. And then I keep mixing up Reza and Rabih. So Rabih emphasized that when there is a high index of severity, you want to evaluate for syncope and seizure simultaneously, because the morbidity is higher in syncope, right? And so another thing that he later emphasized was that syncope evaluation is also more revealing and more productive as compared to a seizure. And then Rabih and Reza went over the immediate tests that are needed in such a case, which include EKG, a point of care glucose, troponins, chest exam to maybe look for aortic stenosis, a CT head, as well as a very important need for a CT chest with contrast to look for 2 PEs. So Rabih said 2 Ps, but then I realized there are actually 2 PEs. So we're trying to see whether there is an acute pulmonary embolism or if there is pericardial effusion. And then Prof. Rez suggested that we should put the patient on telemetry in case we have another, upcoming episode of loss of consciousness. Then another thing that is important to keep in mind is if you see that a patient has chronic pulmonary hypertension, the heart is going to adapt and you will see right ventricular wall thickness. But if the right ventricular wall thickness is absent, we are thinking along the lines of acute pulmonary hypertension. Then, as for the causes of syncope, if you're thinking along the lines of a cardiac syncope, we are going to try and identify between structural versus arrhythmogenic causes. And how do we do that? We assess through a CT chest with contrast, as well as or an echo. And then if we're thinking of cardiac causes, we're thinking of aortic stenosis or mitral stenosis versus pericardial issues like pulmonary effusion or pulmonary embolism. And again, these are more morbid causes, the pericardial issues. And then for the POCUS finding that we had, I just want to emphasize this point. We have our POCUS guru in the chat, Dr. Ravi, and I saw the chat and I added that to my teaching points immediately. And I would like to highlight that again, that if you see right ventricular dilation on the POCUS, you want to think of volume or pressure overload states of the right ventricle. You want to think of right ventricular cardiomyopathies or right ventricular infarction. And then the classic thing that you see on the EKG, which basically tells us that it's the PE, is the S1Q3P3. And lastly, Uncle Bob really emphasized something that is actually quite important in the history, which should not be missed, is to look for, if you see diaphoresis, it is a very major clue in the history that should make you think of a pulmonary embolus. So it has a very high predictive value. So thank you, Uncle Bob. Thank you, RLR. And thank you, everybody in the chat, for teaching us and enlightening us.
Love the structured teaching point, the energy, the content. Thank you so much. That was phenomenal. Uncle Bob, sign us out.
I forgot how he said it. And then remind me what I'm supposed to say.